All right, I put on the captions and we're gonna go for it. So this is our high yield micro review. The goal here is to have this be as broad but as specific as possible. So it was a hard grab for me to do. The goal is pattern recognition, pathophysiology, and anatomical integration, which we know is heavily tested on your NPLEX 1 exam. So we're not going to try to memorize isolated organisms in this presentation because there's so many. We're going to try to understand how different virulence factors in our microbes interact with our host anatomy and how they can affect our immune defenses. And from there, we can recognize patterns that can kind of apply to multiple different microorganisms, multiple different pathologies. It can help us study a lot of information in a amount of time. Throughout this lecture, I'm going to be connecting micro, histo, physio, and clinical presentation. That it really mirrors how NPLEX is presenting things from a clinical vignette perspective now. Really, I want you paying attention to buzzwords, risk factors, and mechanistic clues. So when we're going through, we have some practice vignettes. Those are things I want you starting to hear or listen for when you're reading. Any buzzwords that we've looked at or identified, any risk factors that can kind of clue you in on what's going on, or any pathophys mechanisms that can help hone in on, okay, this is what we're thinking about, or this is what we're talking about. This will help us narrow our answer choices down. The four main conditions we're going to focus on today are pneumonia, meningitis, gastroenteritis, and spinal cord infections. That's like your tetanus, your botulinum, your rabies, etc. Because there's a lot of different microorganisms, but one like singular pathology that we can branch out from. These aren't random groupings either. They tend to be highly frequently tested on components of your NPLEX board exam, where we can really see micro be in contention with organ-specific anatomy and physiology. I have some anatomy, so there's some anatomy reviews embedded in this, as well as a little bit of phys, and then there's practice questions. So we'll kind of go through those as we get to them. And I really tried to integrate it as good as I could for a review class. When we're thinking about each question, when we get there, I want you thinking about barrier failure. So what barrier, what immunologic mechanism failed that allowed this infection to happen? What immune defense was bypassed? And what structure explains symptoms? That's how we're going to tie in our anatomy. So our review on pneumonia, it's an infection-driven inflammatory process of our alveoli. Our defining feature for pneumonia is intra-alveolar inflammation. So inflammation inside our alveoli. This leads to impaired gas exchange on a structural level. This occurs when our alveolar spaces that should be filled with air become occupied by fluid, immune cells, fibrin, and even red blood cells, in some cases if we see hemoptysis. The specific pattern of inflammation will depend on location, whether it's lobar, bronchopneumonic, or interstitial, but it will reflect both our pathogens that are involved and how our immune system's responding to said pathogens. So really, if you think about pneumonia, it's a failure of lower respiratory defense systems, including our mucociliary clearance, our alveolar macrophages, and IgA-mediated immunity. So those three systems failed for us to get pneumonia. Okay? So looking then at our clinical characteristics, this is pretty straightforward. We're going to see fever, pleuritic chest pain, and cough. This is coming directly from inflammatory mediators that are acting on lung tissue and pleura. A productive cough is typical of our alveolar-based infections because we're trying to clear out mucus. So when we see our alveolar-based infections will often be lobar in a lobe of the lung or bronchopneumonia in our bronchioles. This is where neutrophils and exudate fill up spaces that should be full with air. In contrast, we'll see interstitial pneumonia is kind of like the cheese that stands alone. It does its own thing. It typically has a dry, non-productive cough, and this is because inflammation is confined to alveolar walls rather than the lumen itself. Yellow-green sputum color that we see oftentimes in our cough is due to myeloperoxidase, which is created by our neutrophils. It's a heme-containing enzyme released from neutrophils. This is a classic NPLEX detail. So like when we see this specific word, myeloperoxidase, think neutrophils, think green mucus, think heme. So these are like these buzzwords. I want to start like, oh, myeloperoxidase, I remembered something with that. Okay, tie it to neutrophils, tie it to infection, tie it to heme, tie it to green, right? We can tie these things together. On exam, these patients will have crackles or rales. This reflects our alveoli popping open against fluid that's trying to keep it trapped shut. So that's why you hear crackles. Bronchial breath sounds will indicate consolidation in our lung tissue. Dullness to percussion, again, fluid replacing air, and egophony, that A to E or the E to A sound occurs when sound transmission's enhanced through a lung that's solidified. So NPLEX is not going to make you diagnose, but they can give you these kind of clinical clues, and they could ask what pathologically or pathophysiologically is causing this change to occur, right? And that's where we care about clinical characteristics, because they can sometimes help clue us into a pathophys change if you know what that clinical characteristic is from. And we love clinical characteristics because we're really good diagnosticians here at NUNM. We sometimes forget about the pathophysiology that underlines that diagnosis. So these are the three patterns I'm talking about. So understanding of patterns is really helpful for us to identify an organism. So if we have a pneumonia that's confined to a lobe or lobar pneumonia, this involves an entire lobe of the lung. It's filled up with inflammatory exudate, and this is your classic Streptococcus pneumoniae infection. So when you think of a strep pneumonia, it's your classic lobar pneumonia. Your full lobe is filled up with gunk. Bronchopneumonia, which is your bronchioles and some nearby alveoli, you'll see more patchy inflammation that are centered around these bronchial tubes. Instead of a full lobe itself, it's around the tubes, and then alveoli that are located next door. This can often affect multiple lobes. So in your vignette, if you have multiple lobe pneumonia given, you're thinking maybe this is a bronchopneumonia. Staph aureus is often a common cause here, Staphylococcus aureus, especially in a patient who had influenza first. So this would be your classic vignette of a patient had a viral infection, they were infected with influenza, then they got worse, now we think pneumonia, Staph aureus would be your bug of choice. And it's most likely a bronchopneumonia. Okay. Interstitial pneumonia is atypical, but still tested, because NPLEX loves the things that are abnormal and uncommon. They love the zebras. This involves inflammation of our alveolar septa, leading to diffuse patchy infiltrates as well, much milder symptoms. We oftentimes think a viral cause or walking pneumonia like mycoplasma, or even Legionella, Legionnaire's disease. So when I think of an atypical pneumonia or an interstitial pneumonia, I think of my atypical or my not as common causes. Aspiration pneumonia deserves just some special attention. It commonly affects the right lower lobe. This is just due to bronchial anatomy. So when in doubt, if it's an aspirational pneumonia, go right lower lobe as your location of choice. And it often involves an anaerobic bacteria or Klebsiella, and it's foul-smelling sputum. That's because of the anaerobic bacteria. So if it's aspiration, right lower lobe, anaerobes, and or Klebsiella, it's going to be your bacteria of choice. These are three patterns. How are we doing so far? Okay. A little different vibe than reviews past. I'm really trying to help you hone in on pattern recognition here and how you can study these things. Okay. So our lobar pneumonia, looking at our pathophysiology, this is going to go through 4 classic stages which reflect our evolving immune activity in our body. So the first two days is going to be our congestion phase. This is when our macrophages, our alveolar macrophages, recognize a pathogen. They release cytokines like IL-1 and tumor necrosis factor alpha, your pro-inflammatory cytokines that cause systemic inflammation. That's going to lead to vasodilation, so increased blood flow to the area, and increased capillary permeability to allow for cells to move in and out of those spaces. So that's going to be your congestion stage, first stage. Your days 2 to 4 is red hepatization. That essentially means our alveoli start to fill up with red blood cells because we've expanded the ability for cells to move in and out of our capillaries. Red blood cells can seep out. So we now have red blood cells getting into our alveoli, as well as neutrophils, as well as fibrin, because the body's kind of trying to trap or wall off this infection so it doesn't spread via the blood. And this gives the lung almost an appearance that looks like the liver. That's why it's called hepatization, like the liver, HEPA. Same idea. Then after that, next 2 days, gray hepatization. That's when our red blood cells then break down, they lyse, they die, and then they're degraded, and that leaves behind just neutrophils and fibrin. Okay, so we just have this inflammatory wall of stuff left behind, almost like a little abscess. And then finally, we have resolution that occurs. This happens as macrophages replace the neutrophils present, so less direct acute inflammation. They break down the debris left behind. They restore the normal architecture. The cells that are going to restore the pneumocytes, our cells that line our alveoli, are type 2. So the type 2 pneumocytes, these are the ones that typically secrete surfactant. They're the ones that are going to replenish the type 1 pneumocytes, which line the wall of the alveoli. So type 2 are the replenishers. Okay. They can differentiate into type 1 as needed. So that's a key component. Right? How are we doing there? That's your pathophys of your lobar pneumonia. It's also kind of your key component of what typically happens with like an acute bacterial infection, right? Pro-inflammatory cytokines, neutrophils doing their business, sometimes red blood cells and other gunk gets in the way. Oftentimes fibers are laid down, we wall things off. Macrophages come in and clean up the mess. Very common pathway for us. Okay. Who's at risk for this? Well, elderly, immunocompromised, of course. Elderly because they have a reduced cough reflex, and also our immune system at this point is less capable at producing a robust of a response. Immunocompromised, this could be transplant patients, this could be patients on steroids, this could be patients with an immunocompromising condition. Again, impaired cell-mediated immunity. Chronic lung disease affects really mucociliary clearance, so we can't get stuff out as well. Our cilia aren't as effective, as well as our architecture of our airway. We might have less functioning airway to start with. And then congestive heart failure predisposes our patients to edema in our pulmonary tree. This can create fluid-rich environments for bacteria to eat and to feed on. So anytime we have an edema hanging around in the tissue space, that is like food for a bacteria to come munch on. So we think lower extremities and cellulitis. We think CHF in the lungs, pneumonia. Anywhere where that fluid can seep into could be a breeding ground for an infection. Okay. All right. So etiology, I have lots of these tables here. How we read these tables is I have like your typical, your atypical, pediatric, and then other aspiration. Oops, sorry, hold on. I then have your strep pneumoniae, for instance, and that's tied to that top line. So strep pneumoniae, most common cause of bacterial pneumonia in adults, versus Staph aureus, most common cause in children with cystic fibrosis or IV drug users, right? So like you can just go straight across with this line. These would be really good flashcards. These also sometimes aren't as helpful, right? Like COPD is tied to 2, Haemophilus influenza or Moraxella. But if you start to kind of pair these words together and you have an NPLEX exam, they give you a vignette, it's pneumonia, they have COPD, you now just have 2 bugs you have to look for instead of 5 trillion, okay? So that's what this table is aimed to do. The main one to know, though, is going to be strep pneumoniae. We'll deep dive into that in a second. It's the most common cause of bacterial pneumonia in adults. Staph aureus is common post-viral. So if it's a post-viral pneumonia, I think Staph aureus. Also IV drug users. Haemophilus influenza, Moraxella, I think COPD. And our atypical organisms, you think of mycoplasma in a young person who has kind of these really like mild symptoms, you're walking pneumonia, right? So that's your mycoplasma. Chlamydia pitsasi, this is your bird exposure. So if there's anything about a parrot, think chlamydia P. So the P for parrot, that's how I remember it. So if there's a parrot or a bird, chlamydia P. It could also be listed as chlamydia pneumoniae. Legionella, this would be water systems. So an old apartment, a cruise ship. If there's a shared water source, air conditioner source, I think Legionella. Also, it's associated with low sodium, hyponatremia, and diarrhea. So if it's like a pneumonia patient, they have lots of diarrhea, or they talk about low sodium, or they're dehydrated, I think Legionella or Legionnaire's disease. And then Coxiella burnetii, this causes Q fever, also culture negative endocarditis. So if we had some connection with endocarditis pneumonia, maybe then I would go to our Q fever or Coxiella. And then some special populations do matter. We can think of neonates being more likely to be exposed to group B strep. We'll see that also with meningitis. Ventilator-associated pneumonia is often associated with Pseudomonas infection, and then aspiration pneumonia with anaerobes or Klebsiella. Okay. So this is how I kind of study and review. A lot of people ask me, how did you review for NPLEX? I created as many associations in my brain that I could, because that led to less memorization, more trigger word or buzzword, just familiarity, I guess. Okay. This is your big check. So strep pneumoniae. This is going to be one of our big conies. We got to know it. Gram-positive, alpha hemolytic. That means that it partially breaks down hemoglobin or partially oxidizes hemoglobin. It's diplococci, so it's going to be circular in pairs or chains. That's what it will look like. It is also catalase negative, so it means it can't evade that respiratory burst as well, at least not using catalase. Catalase positive, who's also gram-positive, and also cocci is going to be your staph species, your Staph aureus. That's a big differentiator. Strep species, catalase negative. Staph species, catalase positive. So back to our strep pneumoniae. Kind of three major virulence factors lie here. It's encapsulated with a polysaccharide that allows us to evade phagocytosis. So it can get out of being phagocytized by macrophages. It has an IgA protease, which breaks down and cleaves mucosal IgA. So again, it can't be even tagged by an immunoglobulin. And then it has pili, which allows it to adhere to cellular surfaces, specifically mucosal surfaces. And then from there, it can increase inflammation and inflammatory response. So those would be your three kind of big virulence factors to know with strep pneumoniae. It is able to colonize the nasopharynx, so it can be asymptomatic there in a host. If a host defense fails, then it could cause symptoms. So that's why we see it often in community-acquired pneumonia. You could see it also cause otitis media, even meningitis. So those are other infections that you can see are strep pneumoniae. Again, who is it famous for? Well, it's the most common cause for pneumonia in adults. It's going to be the leading cause of otitis media in children and kiddos. There are some vaccine distinctions that they could ask about just from like a what do they do in the body, not a who to give this to. So conjugate vaccines allow for a T cell dependent IgG response. This helps with the young and the old, the kiddos and the elderly, versus a capsular polysaccharide vaccine gives an IgM response only. So that'd be like a quick acute response only, and that's to the capsule that encapsulates strep pneumoniae. If you see a question that emphasizes asplenia or humoral immunity, think encapsulated organisms, and then strep pneumoniae would be one. So they're talking about asplenia, if they're talking about spleen stuff and infection, and what's the most likely organism to cause this in this patient or to cause the most harm in a patient, they're asking you which one of these organisms is encapsulated. And there's lots of different ones that are, strep pneumoniae being one of the infamous ones. So when in doubt, I might choose this one. Okay. My last piece on the lungs is just a little connection. We'll do a practice question to kind of tie it together. Is on our alveoli and histology. We've talked about ciliary clearance and things like that. So gas exchange occurs across our air-blood barrier. It has to be really thin for this to happen. And this barrier is our type 1 pneumocytes in our alveoli. It's type 1 pneumocytes, double basement membrane, and capillary endothelium, the lining of our capillaries. Any process that makes this barrier thicker, edema, fibrosis, exudate, will impair oxygen diffusion in the body, will affect our ability to perfuse. Pneumonia disrupts the structure acutely by filling our alveoli with inflammatory gunk. This can cause hypoxia, this can cause dyspnea. So that's our connection here. Our type 2 pneumocytes are not flattened, they're cuboidal because they have to produce something. So anything that's cuboidal is probably producing something, or it's taking in a lot more of something, versus anything that's squamous and flat wants stuff to move through it, right? So our cuboidal cells, our type 2 pneumocytes, are cuboidal because they produce surfactant. This decreases surface tension in our alveoli, prevents our alveoli from collapsing, or prevents atelectasis, which is alveolar collapse. That's what atelectasis is. Surfactants stored in an organelle called a lamellar body. I think of lamellar or lamellae or lamella in the body. It's used lots of different places as like a storage hub, right? We have lamellar bodies as an organelle inside our type 2 pneumocytes. We have lamellae as these kind of like circular places where osteocytes hang out in bone. We also have lamellae where our our fiber containing cells are. I think they're like, what are they called? Fibroblasts, fibrocytes. I can't think of them right now. But anytime I think lamella, it's like a space that holds stuff. Okay, so whenever you see that word, it's a space that's holding something. Type 2 cells are acting also as alveolar stem cells. So this is what's regenerating a damaged or broken down alveoli. They can proliferate, they can differentiate into type 1s as needed. Okay, all right. The last cell in question is our alveolar macrophages. They're the first line of defense in the lower respiratory tract. So who's going to respond first to any lower respiratory tract infection? It's going to be our alveolar macrophages. They phagocytose any inhaled particle or pathogen that's trapped in mucus. They then move upward towards our bronchial tree. They hijack our mucociliary clearance system. So they ride the wave of the cilia. That's why if cilia die, or are paralyzed from tobacco use, for instance, that can affect clearance. These cells also can initiate our inflammatory cascade by releasing cytokines. And so failure of these functioning macrophages, if we're smoking or immunosuppressed, predisposes pneumonia. Great, we're gonna get to our first practice question. This is a small one. I don't have a big vignette, which is nice. So don't go ahead unless you want to cheat and see the answer. Okay, so which of the following cell types of the alveolar epithelium is correctly matched with its function? NPLEX loves these kind of dual statement questions. So we have to figure out if it's a type 1 pneumocyte, type 2 pneumocyte, or dust cell, which is an alveolar macrophage. And we have to decide if they're appropriately matched. So type 1 pneumocytes, dust clearance, that doesn't necessarily make sense. So we could probably get rid of A as an option. Type 1 pneumocytes, surfactant production. Well, who does surfactant production? 2. Yep, so we know that one's wrong. Type 2 pneumocytes, cell proliferation regeneration. Do they do that? Yes, possibly. We just maybe learned that, so possibly, yes. Dust cells are macrophages. Do they do gas exchange? No. So now that we've gone through our answer types, we can see we have really only one that makes logical sense, and that is C, and C is our correct answer. If you don't believe me, here's your reminder. Our alveolar epithelium has to be thin to facilitate gas exchange. Type 1 pneumocytes are what makes up that thin epithelium. They make up the walls of the alveoli. They're the ones that facilitate gas exchange. The type 2 pneumocytes facilitate surfactant production. Type 2 pneumocytes can become type 1 pneumocytes if needed to for regeneration. Dust cells or alveolar macrophages, they're the phagocytosers for small debris. Okay, yeah. Exactly, second part. So the question was, I'm just going to repeat it for the recording, is type 2 pneumocytes, do they help with proliferation and regeneration by secreting surfactant, or can they themselves turn into type 1 pneumocytes? And it is in fact the latter. They can themselves turn into type 1 pneumocytes. So our type 2 pneumocytes have two potential, you could say, functions. One is producing surfactant to prevent collapse of our alveoli. And the second function is they can divide and act as a stem cell, changing their function to become a type 1 pneumocyte as needed. So that's what our type 2 pneumocytes can do. Our type 1 pneumocytes, they're flat. All they can do is just be present as the lining of our alveoli, and they're just allowing a space for gas exchange. So if they die, there's no goods inside of them to regenerate or to recreate new cells. That's what our type 2 pneumocytes do. Thanks. Yeah, good question. Good clarification. Any questions from our online house before we move on to meningitis? That's our quick and dirty run through pneumonia. Okay, so three key things for pneumonia. You should know strep pneumoniae. You should be able to differentiate lobar from bronchopulmonary from interstitial and kind of know bugs that might be associated with each. And you should be able to understand the pathophysiology with developing pneumonia and how that ties into the physiology of our type 1 and type 2 pneumocytes. Those are the three key pieces I want you to pull from that section. Okay. How's my tempo? I know I'm going fast. Is it too fast, too slow, or are we okay? I got thumbs up, thumbs up, thumbs up. Okay, I'm getting thumbs up all around. Sounds good. We'll keep flying. So meningitis infection or inflammation of the meninges. So we will be reviewing meninges here, but meninges again are our protective membranes surrounding the brain and spinal cord. It becomes dangerous because inflammation happens in a fixed space, our fixed intracranial space. So inflammation and swelling, it can escape, right? And that's going to cause problems potentially long term because edema, immune infiltrates can rapidly increase intracranial pressure, decrease cerebral perfusion, and lead to herniation and potentially lead to kind of like a stroke-like scenario where patients are actually losing blood supply to certain components of their brain. On NPLEX, the key is to recognize meningitis as kind of a symptom and then use age, immune status, and exposure clues to figure out the organism. Because they're almost always going to give you meningitis as a diagnosis, or they'll give you enough where they're like, nuchal rigidity. Like, okay, they have meningitis, probably. And then, but based on the other stuff in the vignette, that's how you'll get to the bug or the organism that's affecting them. Mechanistically, most bacterial meningitis results from organisms that either colonize the nasopharynx and get in through the bloodstream or directly enter via trauma or potentially contagious spread. So we'll look at all three. Risk categories are pretty high yield because they can map to predictable pathogens. So our neonates, we have an immature immune system. You also have exposure via the birth canal. So group B strep, E. coli, listeria. These are all things that either vertically transmit like listeria, or you could potentially have access to through birth, right? E. coli or group B strep. That's why we test all pregnant women for group B strep and treat. Okay. Elderly, our immune system's not working as well. We have higher comorbidity rates. So we think strep pneumoniae. We also think listeria again. Remember, listeria is the young and the old, or the people who don't have good fighting immune systems. People who are healthy and have a good, strong immune system, listeria is really not going to cause much of an issue. Maybe a little bit, but not a lot. Are immunocompromised, reduced cell-mediated immunity, kind of like our elderly patients in some aspects. Broader organisms, again, it's going to be listeria. You could see maybe some weird organisms like cryptococcus, tuberculosis. These are where your abstract ones come into play. Think cancer, think immunosuppression, think HIV. Those conditions can lead to these kind of weird, funky meningitis-causing organisms. Pregnancy, shift away from cell-mediated immunity makes Listeria monocytogenes a classic board association. I'm saying it 3 times because I cannot tell you how often I see this one come up on boards and how many students miss it. So pregnancy, neonate, elderly, immunocompromised. Think about, don't sleep on Listeria. We're going to look at another chart here in a second that talks about some other normal ones. And then your classic like crowded college environment, young adults, healthy immune system, military exposure is going to be your Necessariae meningitidis. You're kind of your classic meningitis presentation. We'll look at them all. From a pathophys perspective, there's 3 routes that you can get into the central nervous system. It is pretty hard. Recognizing the route of spread can help narrow down your organism because they don't all like to go the same way. So hematogenous spread, going from mucosa to bloodstream to crossing blood-brain barrier, or even getting in through the choroid plexus, which is creating our CSF. That's classic for strep pneumoniae, Neisseria meningitidis, H. influenza, and even Listeria. So kind of your 3 classics, strep pneumoniae, Neisseria meningitidis, and Haemophilus influenza. They all can go via hematogenous spread. Direct trauma, think skin flora getting inside the central nervous system, so Staph aureus is going to be your big one there for direct trauma. That's with any kind of wound or surface infection. If it's exposure from outside in, think Staph aureus. And then contagious spread, spreading from sinuses or our otitis or mastoiditis. Strep pneumoniae by far and large is going to be your most common one here. Once any bacteria get into the CSF, they can replicate really quickly because CSF really doesn't have a lot of humoral immunity. And so this can really lead to a big cytokine storm. What are we going to see clinically? Rapid onset, classic triad, fever, nuchal rigidity, and altered mental status. You won't see them all necessarily always. You could potentially see them mention a meningeal irritation sign like Koenig or Brudzinski. It just reflects pain and reflexive posturing caused by our meninges becoming inflamed, right? We put our head down and the patient reacts, right? Tries to get out of that flexed position. Other symptoms, photophobia, nausea, vomiting, seizures. That's really related to increased intracranial pressure and cortical irritation. Hemodynamic instability like hypotension or tachycardia, especially if we're concerned about meningococciemia, essentially the bacteria in the meninges getting into the blood. If you have purpura or petechiae, the rash that's non-blanching, huge clue towards Neisseria meningitis. So when in doubt, and I see petechia or a non-blanching rash, it is Neisseria meningitis until I'm proven otherwise. This is because they have endotoxins. So they have endotoxin-mediated vascular injury. So they can essentially break down the vasculature via their endotoxin. So it makes it pretty hard to compete with that. Typical pathogens listed, like I said before, strep pneumoniae, Neisseria meningitis, H. influenza, type B, and Listeria. Some atypicals would really be exposure, like trauma. That would be your Staph aureus. Viral or aseptic meningitis has come up, especially recently. Viral meningitis is typically less severe symptom-wise than bacterial. It often presents with more generalized viral symptoms like malaise, myalgia, sometimes a maculopapular rash. Most common cause is going to be an enterovirus, especially in the summer or the fall. Then you can think of some others like your HSV or VZV. There's lots listed here, but if you're going for most common, think of an enterovirus. That would be your most common cause of viral or aseptic meningitis. Let's see here. HIV would be another consideration in an immunocompromised patient. One fun, or not really fun, but one important component to note is subacute sclerosing panencephalitis. This is high yield. It's due to persistent measles infection in the central nervous system with a rapid progressive neurologic decline. It's typically more encephalitic, so more brain than meninges, but it's a board favorite because it links vaccines, public health, and neuropath. So if you see anything about measles and then neuro symptoms, or if you're suspecting there's like a measles picture or a vaccine hesitancy picture and meningitis type presentation, I would go measles if that's an option for a viral cause. Neonates, let's see here. This is my atypicals. Oh, sorry, atypicals first. So if your meningitis presentation is not your classic meningitis presentation with petechia, nuchal rigidity, etc., we can broaden our differential a little bit. So you could see Mycobacterium tuberculosis. This would be more of a subacute onset, cranial nerve palsy, basilar meningitis, more common in an immunocompromised person. You could see late stage Lyme, Borrelia burgdorferi. It can cause like meningitis-like syndrome. It classically is associated with cranial nerve 7 palsy, 7 being which cranial nerve? Facial, doing what? Facial expressions. Yes, those online, you missed my beautiful facial expressions. Thanks. But yeah, cranial nerve 7. So if you hear a meningitis type presentation, you have a cranial nerve 7 palsy or facial nerve palsy, think potentially Lyme, think late stage Lyme, neuro Lyme, Borrelia burgdorferi. Cryptococcus neoformans, this is strongly associated with an impaired cell-mediated immunity. India ink will highlight the capsule. India ink is a stain, and that will highlight the capsule in this specific bug. So that would be if there was something mentioned about specific stain type, like 1 in 200 questions, they talk about a stain type, and most of the time it's acid fast and tuberculosis. But if they did, India ink, cryptococcus. And then rickettsial disease, this would be tick exposure plus petechia. So if you had tick exposure and petechia, think rickettsial consideration. Typically, this would be a systemic vasculitis type illness that has central nervous system involvement. That would be when I would think rickettsial. Okay. They'll probably give you a classic meningitis, but if they give you a non-classic, these would be the 4 I'd look out for. Our neonatal meningioencephalitis is really just neonates present differently. They can't reliably describe our symptoms. Their immune system's not mature. So instead of headache and photophobia, you have lethargy, poor feeding, emesis, hypotonia, maybe a non-specific fever. Bulging fontanelles would reflect an increased intracranial pressure. A high-pitched cry as a classic neuroirritability sign. And so some organisms here kind of are your foundational neonate ones to think about. Group B strep or Streptococcus agalactiae, same. This would be from maternal colonization, so vertical transmission or maternal colonization to neonates. E. coli, these are oftentimes capsular strains of E. coli, K1 being the type of capsule, not as important. Again, this would be likely exposure from your typical rectal or own like GI flora. Listeria monocytogenes, food exposure, your unpasteurized milk, transplacental exposure or peripartum. And then enteroviruses like Coxsackie virus being one of the big ones can show up in neonatal CNS disease. I really wouldn't lean too much into lumbar puncture tables because we're not diagnosing on this test, but I have seen them throw in some stuff on answers that could help you narrow things down if you know, like, is protein present or not present, is glucose present or not present. So here's my like quick and dirty way of looking at a lumbar puncture table for meningitis. Bacteria is going to have the highest neutrophils compared to viral and fungal are going to be variable, but really going to show more lymphocytes overall. Fungal is going to have the lowest lymphocyte, so lowest white blood cell content. If we're looking at glucose, bacterial is going to be the lowest, viral will be higher, and then fungal is variable, so it could be in between. If we're looking at protein, bacterial and fungal are higher, viral is lower. And then gram stain, viral and fungal don't have a gram stain. Bacterial, it'll depend on the bacteria. So I'm looking at my, my lumbar puncture clues. If I see high protein, low glucose, and neutrophils are my friend, I'm thinking bacteria. If I see high protein, low glucose, I'm already thinking bacterial. If I see high protein, variable glucose, like maybe a normal glucose or a lower glucose, I'm thinking fungal. If I see low protein, high glucose, I'm thinking viral. So that's the level of depth. I would not memorize numbers. I would not spend a lot of time on this, but it can help hone in if maybe the clues they're giving or maybe the organisms they're giving are unclear. Age, I often think this one's more helpful, okay? And there is a star here because Staph aureus is always a potential cause for all ages, specifically if there's a penetrating head wound. So Staph aureus is in all of these categories, so I just put it below because it was boring. We want to memorize this age stratification because it's repeatedly tested. This is going to be your best bet for choosing a bug with a meningitis question. So a neonate or a young infant, group B strep, Strep agalactiae would be my top, then E. coli, then Listeria. Okay, so by order of which one I'm thinking first. How am I going to know? I'm going to look for other clues given. Is it gram positive or negative? That can help me rule things in or out. It can help me separate strep from the other two. What's its shape? What was their exposure risk, right? That's how I'll narrow down between these three bugs. Older infants, children, or young adults, they all have the same. So N. meningitidis is my top, then strep pneumoniae, then H. influenza. H. influenza would be less common with vaccines, but if we're talking about maybe a unvaccinated population or a population that doesn't have access to vaccination, so if they anything about vaccines, and it's in that kind of category of children to young adult, you could think about H. influenza, H. flu. Middle-aged adults, really strep pneumoniae. Neisseria meningitidis is less common for your middle-aged adult. And then older adults, strep pneumoniae, Listeria, and then any gram-negative bacteria, just because their immune system's not as good at fighting it off. So that would be kind of that's my risk stratification here. Yeah. Yeah, both of them can have petechia, but if there's petechia, I definitely jump to Neisseria meningitidis first. Neisseria meningitidis is going to be a gram-negative bacteria versus strep is going to be a gram-positive. So gram stain can really help. They're both coccized. They are both circular. So morphology won't help you there. Other things, I think it would be really the endotoxin component. They both have capsules, they both have protease, they both can do adherence. So the major difference is Neisseria meningitidis is going to have an LOS endotoxin. a lipo-oligosaccharide endotoxin, whereas strep does not. Strep pneumonia does not. That's why you see that big like cytokine storm, vasculature injury, petechia is likely, or purpura, so like a big rash. So if I see rash, I think Neisseria is probably a good guess. If there's nuchal rigidity but no major rash, or the rash isn't as prominent, then I might go with a strep pneumoniae. And gram stain will really help. Yeah, 1's gram-positive strep, 1's gram-negative Neisseria, but sometimes they don't give you a gram. So yeah, does that help? But both circles. Okay, awesome. So we'll finish up meningitis, then we'll take our break. So Neisseria meningitis, again, it's gram-negative, like we just talked about. It's a diplococcus, so it's going to be 2 circles together. It grows on Thayer-Martin media. Why is that important? They've mentioned it once in the past couple of years, so I just put it on here. When they mention a media in an NPLEX exam, I add it to my list. So take that with what you want. Probably not high yield. Ferments glucose and maltose. That's what it likes to eat. The maltose detail also distinguishes it from N. gonorrhoeae. So the other Neisseria species doesn't like maltose. It's oxidase positive. That means it can be it's also facultative intracellular, so it can be inside of a cell if it wants to, or outside of a cell, so it can kind of hide itself away. The cell it likes to be within is a neutrophil, loves to hide inside a neutrophil. Pathogenesis is kind of stepwise. It's going to colonize the nasopharynx. It's going to spread via respiratory droplets, gets into the bloodstream, reaches the central nervous system by hijacking the choroid plexus, and then virulence factors make it pretty dangerous. So it has pili. Pili allow it to adhere to mucosal regions, so it has really strong mucosal attachment. So it's hard for us to like wipe it off once it gets attached. IgA protease, just like strep pneumoniae, it can cleave our mucosal IgA, so it can promote colonization, promote sticking to those mucosal regions. It has a polysaccharide capsule, again, like strep pneumoniae, so this prevents it from being phagocytosed. It helps evade complement, so it really can help evade immune mechanisms. And it has a lipo-oligosaccharide, or an LOS endotoxin. So we'll look at some endotoxins further when we look at gastroenteritis. But this is what triggers a cytokine storm, vascular damage, petechia, purpura, and septic shock. So if you see meningitis, petechial rash, hypotension, think Neisseria meningitis until proven otherwise. Who are the meninges? Oh my gosh, we haven't thought about this since first year probably. So skin is 1, periosteum 2, bone, skull is 3, dura mater is 4. This is the periosteal or endosteal layer, the layer touching the bone, okay? 5 is the other part of the dura mater. This is the meningeal layer touching the meninges. 6 is the arachnoid mater. In here, with this blood vessel, that's your CSF space, your subarachnoid space. And then in contact with the brain itself is the pia mater. So I figure out which way you like to memorize. I go out to in because it's easier. I'm like, oh, someone had a penetrating head wound. Out to in, what's my order of stuff? So out to in again, skin, periosteum, bone, dura mater, the periosteal or endosteal layer, dura mater, the meningeal layer, arachnoid mater, your subarachnoid space, pia mater, brain tissue, cortex for this instance. Okay. This would be just, you should have this in your brain. If I see a neuro question, this is like my trigger to write this down in order, like however it works for you. Sometimes for me on NPLEX, it was really helpful to have like some stuff I could just like throw out at random if I saw a trigger word. So if I saw meningitis or nuchal, I just like write this out because then it was a dopamine boost. I was like, oh, I know something. And it also could help me tie in anatomically to where things are at. So especially if you're struggling with anatomy, having some of these like quick and dirty things that you can easily write out and easily have memorized can help place you in questions and help kind of ground you in your space. Meningitis from a clinical perspective involves the subarachnoid space. That's where our cerebral spinal fluid, our CSF, is circulating. It's between the arachnoid and the pia layers of our meninges. That's why a lumbar puncture sample, it samples CSF from that compartment. So understanding where the CSF lives, where it circulates, can help us understand this infectious process, as well as why symptoms like headaches or papilledema can occur. Because we're having swelling in this meningeal layer. Our blood supply, another key thing that NPLEX loves to do is blood supply. So to the dura mater, again, dura mater being that like outer layer of our meninges, the middle meningeal artery, or the MMA, is going to be the artery that serves the dura mater the most. So when in doubt, choose the MMA, the middle meningeal artery. Okay, it's also pointed out here. It's this one. My thing's got, here, let me not do red over a red artery. That's unhelpful. It's this one here. This is your MMA. Okay, MMA right here, middle meningeal artery. This branches off the maxillary artery. So maxillary artery coming up by our maxilla, branches off, creates the middle meningeal artery, goes into the skull via the foramen spinosum. High yield, right? Artery traveling through a bony hole in the skull. Awesome, NPLEX, right? So MMA comes from our maxill artery, goes through the foramen spinosum. It's going to serve our dura mater. Okay, this is probably one of the most testable anatomy facts because it's classically associated with epidermal hematomas. So this is a classic NPLEX anatomy vasculature question. And this is where we have arterial bleeding between the skull and the dura, essentially. It's from this artery. The accessory meningeal artery is just the artery lying next door to the MMA. In my top picture, I realized that here it kind of got skewed. My arrow went away, but it's this like tiny little one that I'm highlighting with green next door. This one can enter via the foramen ovale, so different entry point. It also comes from the same branch artery. So the accessory meningeal artery comes off of the maxillary artery as well, or sometimes it branches from the middle meningeal artery. So I like to think of maxillary to middle meningeal to accessory because like a straight line is so much easier for me to remember. And I just remember that middle meningeal is foramen spinosum and accessory is foramen ovale. When reviewing neuroanatomy, anytime you can learn what goes through the holes of the skull, that's a high yield anatomy question for NPLEX. So anytime you can pull those together, those would be high yield things to study for anatomy versus there's so many other things that anytime you can tie, like loop those pieces together, really important. Okay. We're going to do a stem now. This is our first stem, and then we'll take a break. So we're going to work this out together. As you know, I love a stem, but our first job is to read the question first. So the question is, which of the following pathogens most likely led to this patient's current condition? Then I'm going to actually go to the pathogens in question. I'm going to look at my answer choices because then I know what I'm looking for. So I have Corneobacterium diphtheriae, I have Haemophilus influenza, I have Listeria monocytogenes, I have Strep egalactiae, group B strep, and I have Strep pneumoniae. So I have a lot of things for meningitis. I have some other stuff that potentially could cause other infections, lots of different age ranges. But now I kind of know what I'm looking for when I go back and look at my vignette. So now we'll look at our vignette together. So we have 55-year-old, so adult, male, fast food worker, is brought into the ER, severe headache, fever, malaise over the last 3 days. Medical history is significant for proximal AFib, gastroreflux disease, kidney transplant 1 year ago, on a bunch of meds, including prednisone. Okay, vital signs include fever, normalish blood pressure, slightly tachycardic. He's oriented to person and place, but not to time, so altered mental, resistance to passive neck flexion, nuchal rigidity, no focal neurologic deficits otherwise. Cardiac exam, we have an irregular rhythm. He does have a history of AFib. Lumbar puncture, we have cerebral spinal fluid, we have gram-positive rods, and we have actin-based irregular movement. What's your approach first when you look at this question? Like, where would you start looking at this stem? You could keep the stem up. I'll give you your answer choices. But when you look at that stem, what is your thought process of how you would start to approach this question? Which ones are, yeah, we were given a gram stain that feels like a really good way to try to like rule in or out what's gram positive or gram negative. So do we have any idea of which ones are gram positive or gram negative here? Okay, we know our strep species are gram positive, so we can keep those in for now. What about others? Okay, we know that B is not gram positive, so then B is off, and B is a cause of meningitis, so that's great because we're thinking potentially a meningeal infection. What about A or C? Yep. Yeah, with corneo, that's a great point. So Corneobacterium diphtheriae is classic for diphtheria, which you have your gray pseudomembrane that you can scrape and bleed. And like, why wouldn't they use that if they were given that? Probably. So we could say like a less likely. I like that. And then maybe we're not sure about listeria, this gram stain. It's gram positive, great. So listeria is gram positive. So we have three. We were given one more component about our gram positivity. It's gram positive rod. So who do we know is a rod versus a circle? What's strep? Circles, right? It's cocci. So goodbye strep. Bye-bye. See you later. And we don't think that our corneobacterium, because there's no signs of any type of respiratory stuff. So we are left with process of elimination just using gram stain and morphology with Listeria monocytogenes, even if you have no idea if that's the right answer. And that's how you go through process of elimination, group brain. We could have gotten there. That is the correct answer. So really, I cannot emphasize it enough. Morphology and gram positivity or gram negativity is going to be your best two pieces to know about bacteria. If you can know more stuff, that's great. We got the patient had meningitis. We were able to get information about gram-positive rods. Another piece, if you knew this about Listeria's virulence, it mentioned actin-based irregular movements. That just means it tumbles as it moves. And that's a classic kind of movement pathway that Listeria does. It has this tumbling motility. It's a gram-positive rod-shaped bacteria. It relies on actin polymerization to propel it through the host cell cytoplasm. So again, it tumbles, it rolls as it moves. This allows it to move from one cell to the other without going outside into the extracellular environment. So that's how Listeria can kind of hide. Their immunosuppressive state and kidney transplant status increases susceptibility because this is not our most common type of meningeal infection, right? It's our most common cause, but he was immunocompromised. And we knew he was immunocompromised because he had a kidney transplant and he was on prednisone. So he's immunocompromised. We're suppressing his immune system. He also is a fast food worker. He could have potentially then gotten foodborne exposure to Listeria monocytogenes, which can contaminate soft cheeses and deli meats. So those were kind of the clues you could have potentially picked up on, but you could get to the answer from just gram positive, gram negative, and from morphology. Okay. Questions before we move and take a break? This is your dichotomous key example of gram positives. I have cocci on the left and bacilli on the right, or rods on the right. So this gives you kind of a list of, here's your staph and your streps is your big cocci gram positive bacteria. And then your bacilli, we have our bacillus species and our clostridium species, and then some other kind of ones over here. So Corneobacterium, Listeria, Actomyces, and then our acid fast, so our tuberculosis species. So when I'm looking at kind of creating my own little study table or diagram in those last couple of weeks of studying, drawing is helpful break from flashcards or computer-based studying. I make one of these, a dichotomous key of sorts. It's not this pretty, it's quick and dirty. I just go, gram positives, let me just try to throw out my gram positive bacteria and see if I can differentiate them. And at the end of each of these, I'd put a condition that they're associated with. That's why I'd add into this for my own personal clinical tie-in.